Welcome to Raaonline. Today's topic is about HIV in labor. So in this topic, we'll be learning about how to manage a woman who's HIV positive and presenting it to you during the labor and postpartum period. And we will deal a little about the infant prophylaxis. So we are not going into detail about the drugs and the antenatal management. This topic is entirely for how to manage a woman who is HIV positive presenting in labor. So I have put under two guidelines. One will be the international ACOG guidelines and another one will be the NACO guidelines, our Indian standards. So we'll be dealing it one by one. So first we'll talk about the ACOG guidelines. So prevention of transmission of HIV from the mother to the baby is one of the major goal, and it is one of the very important thing that has to be done when you take care of a pregnant woman who is HIV positive. So mother to child transmission and fetal exposure to the virus, usually what happens, the mother to child transmission takes place when the baby is getting exposed to the virus. This can happen during delivery. During the labor process, what can happen? This infected cervicovaginal secretions with the virus may infect the baby. The second one, what happens is that during uterine contractions. So during uterine contractions, the virus in the blood may go and affect the baby. So usually it takes place during the labor process. So what they say is that HIV infected pregnant women who's on an ART therapy, who's on a combined ART therapy, the triple drug regimen, and whose viral copies in the blood is less than 1000 copies per ml, then the risk of transmission to the baby is less than 2%. It's around 1 to 2% only. So, if you effectively treat the patient antenatally, you can prevent the complications and you can also save the baby. So, what does these guidelines say? So, how will you determine? The first thing is always the mode of delivery. So, how are you going to deliver the baby? So, if the baby is having a high viral load, so high viral load means more than 1000 copies. So, if the baby is having a high viral load, then you can go to an elective cesarean section at 38 weeks. So 38 days, that is 30, when the 38 weeks starting, you can start her, you can go for an elective cesarean section. Why 38 weeks? Because sometimes the woman may go into labor, her membranes may rupture, and that might also lead to various complications. So whenever, if the viral load is high, we straight away go to elective cesarean sections. So low viral load. In low viral load, the risk of transmission is very low. It is less than 1 to 2%. And if the woman is on combined ART, the triple drug regimen, and along with if the copies are less than 1000, then the risk of transmission is only 1 to 2%. So in that case, you can go for a normal vaginal delivery. Normal vaginal delivery can be done at 40 weeks. So even if the patient is presenting you in labor, her membranes are ruptured, she is presenting with PROM, and if a viral copy is less than 1000, you need not worry about the risk of infection because it's very low, it is only 1 to 2%. You can wait for spontaneous labor unless and until there's an obstetric indication to take up the patient for a cesarean section. You can do a normal delivery in a low viral load patient. Keep that in mind. So next is, so usually when a woman is coming to the antenatal clinic and you're testing out and she is HIV positive. So if she is positive for the first time, you will start her on combined ART. And if she is already HIV positive and she is on ART, what we will do is that we have to monitor the viral load in the blood. So you have to monitor the RNA levels. So when and all you will do this RNA levels. The first antenatal visit, you will measure the RNA levels. Followed by, you can start the therapy. If she is positive, you can start the therapy. And you can repeat it 2 to 4 weeks after initiating the therapy. Followingly, what you will do is, you will do monthly once. So, monthly once until the RNA levels become undetectable. So, undetectable in the blood until the RNA level falls, you will be doing it serially monthly once. Followed by, you can do every 3 months until delivery. Finally, what you have to do is, you have to measure this RNA level around 34 to 37 weeks so that you can decide whether to deliver the baby by a normal vaginal delivery or a cesarean. So, you have to do the RNA level, you have to measure the RNA level around 34 to 37 weeks.